Hi everyone, my name is Avery Zhou. I'm currently a third year, almost fourth year medical student at the Kirk School of Medicine at UNLV. Today I'll be presenting a case of Horner syndrome secondary to edema of the longest colli muscle, so this will be a case report. So as a brief introduction to Horner syndrome, this is classically characterized by the triad of ptosis, anhidrosis, and meiosis. Ptosis meaning drooping of an eyelid, anhidrosis meaning lack of sweat, and meiosis meaning pupil constriction on one side. This can be caused by a variety of different reasons, but ultimately it is caused by any disruption to the oculosympathetic pathway. This pathway originates in your hypothalamus, travels down through your brainstem, down into your cervical-thoracic junction where it turns back up, goes over your lungs, and goes into your face where it innervates functions such as lifting your eyelid, dilating your pupil, and sweating. So any disruption to that pathway can cause Horner syndrome, and common causes and common concerning causes of Horner syndrome include things such as brainstem ischemia, demyelinating plaques, Pancoast tumors, vascular dissections, and cavernous sinus thrombosis. So here I present a case of Horner syndrome that is a unique presentation not due to any of those aforementioned reasons. So as a brief history, this is an 18-year-old male. He has a history of polysubstance abuse, and he was found unresponsive in a car crashed into a dumpster. He was unaccounted for about 7 hours. When EMS arrived, they administered naloxone, but it had no effect. So he was brought into the hospital with a Glasgow Coma scale of 3, so he was unresponsive, and so he was intubated for airway protection. Initial findings were significant for leukocytosis, which is elevated white blood cell count, positive cannabinoids on urine toxicology screening, but that was it, and rhabdomyolysis with a creatine kinase that peaked up to 4,000, with a normal range being between 20 and 200. CT of his head showed no abnormalities. CT of his cervical spine showed no fractures. Initially, he was thought to have a STEMI, so he was taken to the cardiac catheterization lab, but he had clean coronary arteries. He was only notable to have severe left ventricular dysfunction with an ejection fraction of 25 to 30%. However, a follow-up echocardiogram showed normal left ventricular ejection fraction of over 60%. So he was admitted to the ICU, and on day 2, he was extubated. The patient remained combative and agitated throughout his hospitalization, and neurology was consulted on day 4 to assess for his agitation and anisocoria. Anisocoria meaning 2 different sized pupils. So upon examination on day 4, neurology found that he was restless and unable to provide any history. His vitals were okay, he was afebrile, but he had been hypertensive up to the 160s throughout his stay. On physical exam, he did have new onset anisocoria with a miotic left pupil and left-sided ptosis. So like I said, meiosis meaning pupil constriction, ptosis meaning eyelid drooping. So this presentation is consistent with a left-sided Horner syndrome. The remainder of the examination was unremarkable. So to determine the cause of this new onset Horner syndrome, we had to do some neuroimaging. So neuroimaging was performed to assess the oculosympathetic pathway, which included a CTA of the head and neck, MRI brain with and without contrast, and an MRI of the neck soft tissues with and without contrast. These imaging results turned out to be unremarkable except for the MRI neck and soft tissues, which I have included here. So on this imaging, you can see there is some enhancement of this left side. This is consistent with edema of the left longest colli muscle from C4 to C7, and you can also see a shorter segment of edema here, which is consistent with right longest colli edema from T6 to T7. So the patient was treated with high-dose corticosteroids to relieve the likely edema that is causing his Horner syndrome, but unfortunately he was lost to follow-up because he left against medical advice. So in our discussion, this is a unique presentation because, as I said, Horner syndrome can be due to a variety of different things, and only 2 other cases have been reported in the literature of Horner syndrome secondary to longest colli edema. One was secondary to a cervical spine surgery, and the other one was due to ipsilateral contusion. So this is the first report of bilateral edema of the longest colli muscles causing a Horner syndrome. Usually, Horner syndrome just resolves as soon as you resolve the underlying problem, so likely his Horner syndrome will resolve as the edema lessens and the compression of the nerve lessens. However, before you can attribute Horner syndrome secondary to longus colli edema, you would have to rule out all the other more concerning causes of Horner syndrome, such as, like I said, Pancoast tumors, demyelinating plaques, brainstem ischemia, vascular dissections, or cavernous sinus thrombosis. These other causes are more concerning and more life-threatening, so these have to be ruled out first before you can attribute it to a benign cause such as edema. So that is my case. Thank you so much for listening. Let me know if you have any questions, but thank you for your time.